demonstrates the change between starting attribution and average attribution over the course of the year. This is of particular interest in 2023 because of the Medicaid redeterminations that are occurring at a national level. DVA began this process in Vermont in April, and it is expected that the number of Vermonters with Medicaid coverage will decrease due to these redeterminations. By comparing what the change was between starting and average attribution in fiscal year 22 to what is anticipated in fiscal year 23, we can see that OneCare is anticipating a slightly larger drop in Medicaid lives. In 2022, there was a 9.75% drop between starting and average attributions. This is before redetermination started. And in the initial budget, they predicted a 13.2% reduction. And in the revised budget, there's a drop of 11.3%. The staff do want to make note that the starting attribution numbers provided by OneCare has fluctuated significantly. In the initial budget, they predicted about 126,000 lives for Medicaid. In the revised budget, they reported 142,000 lives. And in their Q1 reporting, which we received at the end of April, it appeared that the starting attribution was about 131,000 lives. And the staff have asked OneCare to clarify this variation. And for more information on Medicaid redeterminations, anyone can visit DVA's redetermination webpage at www.diva.vermont.gov/unwinding. And I will now turn it over to Matt, who will walk us through the ACO's financials.
Hey. Can you all hear me fine? Great, thanks. So looking first is at a really high level income statement, just to orient you, you can see the revenue rows at the top and the expenses at the bottom. Just want to kind of point out, you can see that $448 million decrease to both lines mirrored on the expense and revenue side, reflecting that there's no budgeted net income projected. We can go to the next slide. This is the same information. I just wanted to kind of expand the expense side out a little bit more so we can see like detail of where things are moving. Here you can see the decrease in the program target revenue mirrored in the expense line. It's basically the pass-through dollars. And then the operating expense cuts below is another major category. As part of one of their conditions, they were required to cut operating expenses by 2%, and I'll speak about it a little bit more later, but they've done so, cutting 2.6%. And we can go to the next slide. So the same as the other view, except we've just condensed the expenses and OpEx, and we're just looking at the PHM and payment reform programs. There's quite a bit of movement between these lines. So I just wanted to make them available so you can see kind of the inner movement, but the net was about $57,000 increase when you include FPP. Also, I'll orient you, there's a $1.6 million on this slide you can see for mental health screening initiative that was not included in the original budget, which is somewhat offsetting some of the PHM cuts, which you're seeing kind of as a result of the self-funded program and attribution updates. Next slide. So just looking real quick, at operating expenses, you can see they cut by 2.6%, and here are some major categories that they cut in the amounts. We can jump to the next slide, and kind of shows the same information, just in terms of a waterfall chart, so you can kind of get a sense of the scale. You can see an increase in contracted services, and part of that is a shifting of some previously staff duties to contract labor. And then the next slide. So this is again looking at the operating expenses, this time just as a concentration. So, looking at 100% of their revised budget, 100% of their initial budget, what's the breakout along those categories you saw before? And You can see that shift from salary and benefits to contracted services, and you can also see the executive salaries being reduced slightly relative to their initial submission. And this is just a table. OneCare is now providing us more detailed information in our budget system when they submit, and we're able to look more at staff counts more granularly. This is just showing the change from FY22, some of the movement, and we're also collecting compensation amounts for along these lines too, so we'll be able to provide more detailed reporting in future periods. And then just looking at the sources, I guess the PHM programs by provider type. So you can see some changes largely due to the movements that we've kind of discussed before, but just wanted to provide this information so you can see kind of where that's playing out and who it's affecting. And I think that was it. I think, Michelle, were you going to discuss this? I can
yeah, I can get this. Thank you so much, Matt.
Great. Thank you.
All right, so this table outlines the changes in the number of attributed lives over the course of the ACO's operations and the amount of population health spending and operating expenses in each of those years. And then we calculated how many dollars per attributed life were spent on both population health spending and operational expenses. And the next slide is a visual of this data. So the bars represent the number of attributed lives in each program year of the ACO. The teal line represents the amount of population health spending per attributed life in each year. And the yellow line represents the amount of operating dollars spent per attributed life in each year. And as you can see in the early years, attribution was low, leading to higher spending per life in both population health and operations. And the operational expenses really leveled off, but with the drop in attributed lives for 2023 due to the loss of those Blue Cross Blue Shield lives, the ratio of dollars to lives has increased a bit to 77 in operating expenses per life. Population health spending has varied, and it seems to be less closely tied to the number of attributed lives.
Michelle, can you pause there for just 1 second?
Absolutely.
Okay, thank you.
All right, so condition 11 required that OneCare report on any changes made to population health programs. A new initiative was added to OneCare's population health offerings, the mental health screening and follow-up initiative. In an effort to support both mental health initiatives and primary care practices, the program offers incentive payments to providers who implement a mental health screening protocol and agree to electronically document the results of these screenings, as well as treatment and follow-up procedures for any positive screens. The mental health screening initiative payments will be paid to qualifying primary care participants according to estimated mid-year assigned attributed lives for all ACO programs at the aggregate payment rate of $9.72 per assigned attributed life. The mental health screenings include the PHQ-9, the PHQ-2 plus the CSSRS, the PHQ-A, and the Edinburgh Postnatal Depression Scale. Condition 11G required that OneCare notify the board of any changes to its risk model. This is tied to condition 16, which, as abbreviated here, states that OneCare shall hold at least $3.9 million of the risk associated with the Medicare Advanced Shared Savings payments and must not pass that amount of the risk on to any OneCare network participants. It appears they have done so and now hold $4.4 million in downside risk and $861,000 in potential gain. at the entity level. The Medicaid risk corridors have been expanded since the initial budget and are now at 3%. The MVP corridor also shifted, and for the UVM Health Network self-funded plan, it's new for the since the initial budget. This slide shows the budgeted risk between 2019 and 2023 and the percent of the risk held at the entity level versus the risk delegated to the provider network. The budgeted risk is worth showing here because it is the risk level OneCare was planning for prior to the onset of the pandemic, when the risk levels, in response to the pandemic, risk levels were significantly lowered. In their initial budget, OneCare brought the total risk level back up closer to pre-pandemic levels for 2023, but the loss of the Blue Cross Blue Shield payer program reduced the amount of risk held at the network level overall. The OneCare held portion of risk in the initial budget was also quite a bit lower than it was pre-COVID. But for context, OneCare typically has taken on risk as a glide path to support HSAs who are newly joining payer programs but not ready to take on the full risk themselves in the first year. And in the revised budget, you can see that OneCare held risk is at a higher proportion of the total overall risk as a result of Budget Order Condition 16. That is where you see the Medicare Advanced Shared Savings dollars. The one item that this is a look very similar to the last slide, but the one thing that wasn't shown is the percentage of risk relative to the total cost of care. You can see that pre-pandemic, it was right around 4%, and since then it has not yet returned back to those same levels. Since we're calling out OneCare held risk, we also want to call out OneCare net assets and equity, which includes a reserve of $3.9 million that the board required in its 2019 budget order, as well as net assets. OneCare also has a $10 million line of credit as required by Medicare. All right, condition 11H required OneCare to report on the sources for their population health funding. Overall, there was a decrease in this funding from $29.9 million to $26.3 million between the initial and revised budgets. Additionally, the way that in which DVA supports these programs has evolved with the changing of the PHM program. When the VBIF program was active, DVA offered $2 million in funding for participating providers serving Medicaid attributed lives under this program, which was paid directly to those providers and not through OneCare. And now that the VBIF program has really just become part of the PHM program, DVA is paying all PHM bonus payments earned by providers for serving Medicaid attributed lives directly to those providers and not through OneCare. The mental health initiative is fully funded from hospital dues, and funding for the Dulce program has shifted from DVA in the initial budget to hospital dues in the revised budget. This is just clarifying that the $1.8 million in hospitals in the hospital dues or participation fees that the board discussed on March 2nd have been allocated mostly to the mental health initiative, with some also going to the Dulce and the remainder to the PHM program. Condition 11J required that OneCare report on their commercial FPP targets. They last reported these to the board in July of 2022, and the target had been set at 0% at that time, where it remains still. With the withdrawal of Blue Cross Blue Shield, all commercial FPP amounts were lost. And here are the key takeaways from OneCare's fiscal year 23 revised budget. There is a new payer program, the UVM Health Network self-funded program. There were changes in both payer risk corridors and the amount of OneCare held risk. There is the new mental health screening and treatment initiative, and the $1.8 million in hospital participation fees were fully spent on population health efforts. And there was a reduction in their operating budget. The next several slides are basically a status chart where we can review where we're at in this point of the year with the budget conditions. Several of them are considered complete. Most are areas where we continue to monitor until the budget is closed out at the end of the performance year. No board action is required today, but I just want to highlight the ones that we will be discussing at the next staff presentation on May 17th. So the first condition, the ACO benchmarking system, we will have additional staff analyses available on May 17th. Condition number 8, there's a technical correction that's necessary, which we will review and discuss on the 17th as well. We will discuss condition number 10. That has to do with the notification of any material change to a budget, and we'll discuss that then. And condition 15. We reviewed that today. There will be a vote necessary, so there will be additional discussion on the 17th. And the other two are monitor. So now, if it pleases you, Chair, I'll hand it back over to you for board questions and discussion.
That was great. Thank you very much. I'll just open it up to the board members for any questions or comments they may have. Appreciating that we will have another presentation Friday and then another in a couple of weeks here. Go ahead, Dave. Go ahead, Dave.
I have a quick question. Regarding the operating expense per attributed live, do operating expenses include any fixed prospective payments, population health payments, any payments to providers, or is it purely operating expenses?
Purely operating expenses, salaries, software, contracted services, that sort of thing.
Okay, and so that went from $53 to $77 per attributed live in the last year is what I saw on that slide, which is a substantial percentage increase, but that's all I wanted to point out there. I think if I just don't understand that correctly.
It sounds like you are interpreting that correctly.
From the initial to the final. Yep. Okay.
Yes, and that,
yep.
that ratio is changed because of the loss of the, the 22% reduction in attributed lives.
Okay. And then on slide 40, there was some funding that went down. Do you know anything about the $1 million less to FQHCs and the substantial decrease to the designated agencies? Do you know if that's related to Blue Cross Blue Shield payments, or is that, are you aware of what led to that decline?
I'll let Matt chime in, but it is my understanding that these reductions mainly were around the loss of attributed lives. But I invite anybody on my team to chime in if might be other reasons.
I think one Carol will have to speak to that a little bit more.
Okay. All right. That's all I have. Thanks.
I have one related to that on slide 40. Were these changes from initial to revised, were they just proportionate to the number of lives before? So i.e., but they just spread across equally how much it was going down, or is there some sort of adjustment to where they were putting spending after the Blue Cross withdrawal?
That That's a great question and not an analysis that the staff has done at this point, but happy to get more information about that and look into that if it's not clearly addressed on Friday.
Okay, I'll just put a pin in it. I might ask them on Friday if we don't have other information. Oh, go ahead, Matt. I see.
Yeah,
Okay.
chime in, Matt.
Sorry, I just wanted to add just for, just to be completely fair. So this is looking at just the PHM programs without FPP. Now, there was an increase to FPP, and if you include that along these, break it down along these categories also, the decrease, it does not look as significant. I don't have the numbers in front of me, so I don't want to speak to it, but I can provide that information, provide that to you all after the call.
That might be helpful to see. Okay.
I can provide the same table just with FPP included as well.
I can maybe provide a little bit, just another way to think about this for Friday. We had the hospital dues that are funding population health stayed, they kept that level so they can continue to fund the programs, which, as Michelle said, was part of the discussion on March 2nd. This decrease overall in PHM, like Matt and others said, I think one will have to speak to. I would assume that it has to do with loss of lives, but I don't totally know for sure. In terms of the revenue side, they did maintain the revenue side, is my understanding, in terms of collecting the hospital dues that they expected to collect in the original budget and allocating that to population health programs. I don't know if that helps or not.
Yeah. Right. Then could you just pull up slide 39? I was going kind of quickly. So fiscal year 22, this is what they submitted in the fall.
Well, that's from their presentation slides. I don't think we required them to submit it as like an appendix in the past, but it was presented in the past year.
Okay. And then the change of 12 FTEs, 11.1 to value-based care, is that because, or 11.9, is that because that's due to the shift of contracting folks to UVM for the data?
We don't have exact details on that, but at least a portion of that is our data folks moving over to the health network, yes.
Okay. Okay, I have nothing else.
You all actually just got my questions. I had similar questions about the drop in population health expenditures, so that'll be helpful, Matt, to get that data. I had a similar question about the FTC count and FTE count. And then I also am just really be curious to hear from them on Friday about the starting attribution for Medicaid. I know you've asked questions about that, but you know, the starting attribution seems quite higher in a year when we're having revaluations of that. So those are my predominant questions, just to foreshadow what I might ask about on Friday if we don't hear more information. So in the meantime, but thank you.
I've just one question and purely clarification for me. On slide 47, there's a statement about population health funding, I think through DVA. And I want to try to square that with the table listing population health payments per attributable life. I think that might have been slide 41. So here's the thing that confused me. That and then there's the table that has population health expenditures. Does the change to flowing through DVA affect this table?
That is a good question. It is my understanding that the DIVA money was not included in this table. So that DIVA money in VBIF would have shown up in 2022. And then for both the and then for 2023, that difference in funding as well, direct to provider, I don't believe is captured. But Tom, I will double check, and I can certainly let you know how those were calculated exactly, whether it includes that money or not.
Okay, thank you.
Mm-hmm.
Okay. And am I correct that we need a break at 4:30 for folks?
I need just 5 minutes,
Perfect.
and I'll be
Okay,
right
so-
back.
Yeah. All right. So we'll turn real quick to the healthcare advocate. That's not to limit your time, but please go ahead.
That's okay. Thanks, Chair Foster. Most of our, I'm going to say all of our comments, questions, and concerns, I think we're just going to save for the hearing on Friday, so we can keep it super brief. Thanks.
Okay. So Michelle, why don't we take a break now? We'll come back we'll take 10 minutes, 4:37. And if you need more time, send me a message and I'll wait. But so it's 4:37. Thank you.
Thank you.
It looks like we have everyone. I don't think there's any other board comments. We'll move to public comment via the raise your hand function. Great. Seeing none, thank you all very much. Oh, no, hang on. We got one. Ms. Wasserman, how are you? Please go ahead.
Yes, thank you. I just had one interesting one point I'd like to question. It would be valuable if we were able to determine the percent of OneCare's population health management payments that were paid to hospitals, who, as we all know, own the large majority of Vermont's primary care practices, and then also contrast that with the percent paid to independent primary care practices for whom these payments are critical. And additionally, I would hope that OneCare on Friday could clearly account for the funds paid to hospitals. And the main question is did the hospital's primary care physicians directly benefit from these funds, or did the funds go to the hospital's bottom line?
Great, good questions. Thank you very much. Any other public comment? Okay, great. Thank you all for putting this together for us. Great job, as always, so thank you. And with that, is there any old business to come before the board? Any new business? And is there a motion to adjourn?
So moved.
I will second it. All those in favor, please say aye.
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 Aye. And the vote carries and the meeting is adjourned. Everyone have a great evening. Thank you.